Good afternoon, everybody, and thanks so much for joining us here on KXAN Live. I'm Will Dupree. We are going to bring you live remarks now from a virtual town hall that's happening. It's a collaboration between the University of Texas at Austin's Dell Medical School and the Travis County Medical Society, and they are discussing with the director of the UT COVID-19 Modeling Consortium about what life will be like after the pandemic. I know that is a big question that a lot of us have had at this point, and the woman who is going to be speaking from the Modeling Consortium is someone that a lot of experts around here have turned to during the pandemic to kind of figure out where things might go in the near future. So she is a good resource, and that conversation will be starting here in just a moment. So let's take a listen as this virtual town hall gets underway. It lasts about an hour or so. That's what organizers are saying. So please stay with us as we bring you this in full right now here in Austin.
To introduce Lauren. So if you've been following this series at all, you've already met Lauren. If you've been following COVID at all in the news, then you know Lauren already. So she's been one of the real leaders internationally in modeling, and we've benefited from that greatly here locally, because we will feed Lauren questions. You know, tell us about what's going on in East Austin. Tell us about what we can expect by the delays in vaccinations. Tell us about what might happen with new variants. And so Lauren then can go back and use that to decide whether it's an important question or not, and if it is, actually generate some additional data. So we have that's guided Austin quite a bit throughout the pandemic, and has been incredibly useful. And I think it's important too, for some reason, I don't know what it is, and hopefully Lauren will do another analysis to tell us what it is, but for some reason, Austin has done unbelievably well in the COVID pandemic, and maybe we can talk a little bit more about that. Compared to other cities in Texas, it's total rates of mortality are half based on population expectations, so really remarkable. And no question that having more data and following the implications of that data have really helped. So with that slightly unusual introduction, I'm going to hand it over to Dr. Myers.
Thanks so much, Dr. Johnson, Dr. Foster. It's great to be here again with you. I think this is my third time appearing, and it's just nice to be here at a time when I think we're all breathing a little bit easier than we have been over the last year. And I wanted to start by thanking all of the physicians in the audience today for everything you guys have done on the front lines to keep us all safe and healthy. And I know sometimes putting yourselves and your families at risk in the process. So let me share my screen. I'll start with the written disclosure. So before I jump into what I want to talk about today, I want to, in addition to thanking you, I want to thank all the researchers that have been hard at work, mostly behind the scenes, doing the kinds of analyses I'm going to share with you today. There are dozens of researchers from UT and other institutions who sort of banded together in the UT COVID-19 Modeling Consortium to provide analyses to support policymakers, public health officials, other sorts of decision makers in schools, community organizations, and the general public in navigating this really unprecedented threat. So I was, and here's the long list of many of the people who've been involved in what I'm going to describe today. So I was asked here today to come back in my third appearance and talk about life after the pandemic. And I will speculate a little bit at the very end about the future, but it's so hard to know what's going to happen. I'm going to spend most of my remarks concentrating on kind of a recap of what Austin has experienced. To some extent, I'm going to reflect on the question that Dr. Johnson just posed of why does Austin seem to have done reasonably well, but also where are we not doing as well, and kind of the more pressing issues just in the coming weeks and months. So I'm going to do that with sort of 5 vignettes, a recap of the pandemic in Austin. We're going to focus a little bit on the staged alert system that's been guiding our policy, emerging variants, our ongoing vaccine rollout, and then a few words about proactive testing going forward. So starting with a recap, and we've all lived through this, but I'm just going to remind you what happened through the lens of this graph, which is our estimate for the reproduction number of the virus When the value is above 1, that means that the pandemic is growing in Austin. When it's below 1, that means it's not growing. It should be on the decline or flat. And so this graph goes from March of 2020, when this all started, out till almost today. And so when COVID first arrived in Austin and we didn't really know it was here and we weren't doing anything about it, we probably had a reproduction number of, well over 2. After we first identified our first cases, we closed schools. And then the city leadership declared our stay home order, the stay home work safe order. And I'm going to mention just a little bit about the modeling behind the scenes. This was the first time our group got a request to do some modeling to help support decision making. And some of those first projections we made about what would happen if we did go into a stay home order versus not go into stay home order were displayed during press conferences to help sort of motivate why the city was making the decision it was at the time. Also sort of behind the scenes, we immediately got requests to do some analyses of the risks of construction work and grocery shopping during that stay home order. And we made some projections about risks to those workforces and to the community at large, along with doing some analysis to help the city decide how many isolation rooms they would need to protect our population of people experiencing homelessness in Austin if and when the pandemic got to those communities. So the school closures, the stay home work safe order, they had the desired effect of immediately causing a very sharp decline in transmission. We estimate that the transmission rate of the virus decreased by at least 75% due to those measures. And then we kept transmission pretty low throughout that period. But then beginning in May, Texas was one of the first states to sort of aggressively adopt the reopening guidelines from the Trump administration. We reopened in our first phase, May 1, second phase, May 18th. And those reopenings and the relaxation of our behavior, and this was before we were all sort of religiously wearing face masks, they had the undesired consequence of causing our summer surge. And our hospitals started filling in June. And when it started to look like we were getting to a breaking point, the state allowed local authorities to enact stricter measures. Then the state issued the statewide bar closures, statewide face mask mandates, and those things together brought our summer surge under control. And then during the fall, there was sort of a constellation of factors that led the reproduction number to sort of slowly inch above 1 and stay at a point where the pandemic continued to grow and sort of grow into the point that we experienced that winter surge. So UT opened, schools opened, people went back to school. There was some relaxation of behavior. We had the Thanksgiving, we had Christmas. And then what you're seeing here is the reproduction number, but if you were looking at the hospitalizations, you would see that, in December, we started really seeing an alarming uptick in hospitalizations. This triggered our stage 5 order, where we really encouraged everyone to essentially stay home, although it was not mandated exactly. That lasted between December 23rd and February 9th, and that had the desired effect of really containing the spread, bringing the reproduction number to the lowest levels measured throughout the pandemic. And since then, we had our catastrophic freeze, spring break, and the rollout of vaccines on the positive side, the increase in spread of variants on the negative side, all sort of combined, putting us in this sort of state of limbo where the reproduction number has been hovering right around 1 for quite a while. So that's the recap. And now I want to go back and talk about some of the analyses that we did almost a year ago in April and May of 2020 to set up our staged alert system that has been guiding our policy throughout the pandemic. And this is really the creation of the system and the maintenance of it has really been a collective effort where we've been providing some analysis behind the scenes, but it's really city leadership, mayor, county judge, public health authority, Austin Public Health, leadership of all major area hospitals, Dell Med, all collaborating together to make a policy and sort of maintain a policy that made sense and achieved sort of local goals. So the question that we were facing back in April of 2020 and April of 2020, when it was pretty clear that Texas was going to force a pretty hard reopening in the beginning of May, was what do we do to kind of safeguard our population? What do we do to kind of keep things safe, yet kind of navigate the challenging political and legal landscape? And so the answer was not going to be, we're just going to lock down, because we couldn't, right? And so, and we didn't want to, right? We didn't want to suffer the social and economic costs of that. So we ended up spending some time just articulating what the goals of the policy would be, whatever the policy looked like. And really we boiled it down to two goals. We wanted to do whatever we could to ensure that we kept our hospitals under capacity, that we never faced the overwhelming surges that we were seeing in the hospitals in Italy and New York at the time. And if at all possible, we wanted to avoid costly stay-home measures or restrictive measures that limited our social and economic lives. The policy levers, we realized, were sort of what you see all over the place. You do different combinations of social distancing and face mask measures, limit gathering sizes, enact face mask regulations, limit occupancy in restaurants and bars, et cetera. And so that ended up being sort of the marching orders at the different stages in our policy. And then the two questions we asked in designing the policy that the modelers helped answer in the background were, what data should the city track to figure out, how strict our measures should be on any particular day in the pandemic? And based on what the data we're tracking, when should we act? And the answers we came up with led to the design and public display of the Austin Alert System dashboard. So this is our key indicators for staging dashboard. And what you see is, this is the data we decided we were going to track as one of the key indicators. Certainly we were looking at other data as well, but this is the main one. And this is the rolling 7-day average of COVID hospital admissions. And then when to act, well, that's those lines between those different colors. So we used models to figure out exactly when we should trigger a change from green to blue, blue to yellow, yellow to orange, orange to red. And those values were based on what we call optimization analysis. We're really trying to figure out what is sort of the last possible moment we can move into red and still ensure we will never have an overwhelming surge, and how quickly can we come out so that we can absolutely minimize sort of the cost to our economy and our society. So that policy was put in place in May of 2020, and throughout the pandemic, we have been evaluating it. We have been pressure testing it as we learn more about the virus, as we learn more about our healthcare capacity in Austin, as the situation changes. We have been testing to make sure that policy still makes sense and sometimes revising it. So, for example, in June of 2020, the hospitals kind of realized they probably had more capacity than we assumed when we first put that policy in place. And so we increased the red trigger, meaning we wouldn't go into a stay-home order or stage 5 order quite as soon. But then at some point during our summer surge, we realized that we were going to hit ICU capacity before hospital capacity, and we changed the triggers accordingly. In the fall, we had even lower capacity for COVID cases because there were more patients in ICUs for other reasons, and so we adjusted accordingly. In December, we did an analysis to figure out when we should trigger the opening of the Austin Convention Center as an alternative care site to accommodate overflow. And throughout this time, we've messaged to the public, and we've adjusted the thresholds as needed. And now we find ourselves in a very different situation. We find ourselves in a situation where we are starting to breathe easier. We're seeing vaccinations roll out at a really good pace. And so now we're beginning to think about, what does our path look like back to normal? Because when we built this policy, it was really, what does our path look like to protect us from catastrophe? And so, we're asking questions like, should we change some of these thresholds so that we can move to stage 2 or move to stage 1 even earlier? And those are the questions of the week. So how did our staged policy work? So again, this gets to Dr. Johnson's question about, how has Austin sort of done, how is it that Austin did better than other parts of Texas? Well, the staging, the alert system seems to have worked as designed. So we went into one stage 5 order, as I just mentioned, and it had the desired impact of curbing the spread of the virus and averting an overwhelming surge in ICUs. So this graph is showing the number of COVID ICU patients through time. That horizontal line at the top shows our estimated capacity for the metropolitan area. And the stage 5 order slowed transmission and prevented those ICUs from exceeding our capacity. So it achieved the public health goal, which was preserving the integrity of our healthcare system, but also to some extent it achieved our sort of socioeconomic goal. When we went into our winter surge, we triggered, along with every other part of Texas, we eventually triggered the governor's GA32 order, which limited elected surgeries and put other limitations on commercial activity. Of all the 22 trauma service areas in Texas, ours was the very last one to trigger those restrictive measures and the very first one to come out of it. So we also spent sort of the least amount of time under these economically restrictive measures. So the alert system seems to do what it was designed to do. However, while Austin, in comparison to the rest of the Texas, did well, and the alert system did what it was achieved to do, we have to recognize that surges are not good. Even if they stay under capacity, they are deadly, right? People are dying during these surges. They're getting very sick. And they're dying, it turns out, at higher rates during these surges than during the sort of more calmer points in the pandemic. So what I'm showing you here along the bottom are the daily COVID-19 hospital censuses for Austin. And these three curves along the top are estimates, and this is very preliminary analysis, but estimates for the proportion of people in hospital for COVID who die in the hospital. And you can see if you look at the 65 and older line, that's the highest curve there, that the in-hospital death rate for COVID patients seems to increase when there are more people in hospitals and decrease when there are fewer people in hospitals. And you also see that signal in the other age groups. And the deadliness, the sort of severity of this pandemic has not been felt evenly across the city. It's been disproportionately impacting different parts of our city. So this is a map of Austin. These are our 43 different zip codes, and they're color-coded in this map according to the CDC's Social Vulnerability Index. So the brown zip codes are ones that are more vulnerable, and according to this index sort of estimates the resilience of a community to stresses, like a pandemic. And so, in general, the more east you go in Austin, the more vulnerable the community, the more west, the less vulnerable. And you can see this by zip code here. And this is again, very preliminary analysis, but this is an estimate for the COVID mortality rate to date in Austin according to zip code. And you can see, just eyeballing it, there is a correlation between how vulnerable a zip code is and how much the devastating impact of COVID has been throughout the pandemic. Okay, so now I'm going to move on to talking about emerging variants. And specifically, I'm going to focus on one that is already pervasive in Austin, the B.1.1.7 variant that emerged out of the UK. We first became aware of it in the beginning of 2021, but it was probably circulating in the second half of 2020 and probably had arrived in the United States, I would say, by October, November of 2020, long before we knew of its existence. So in early February, we first became aware that the variant was circulating in the UT community, and we became aware of it through the testing that we're doing on UT campus. And based on very scant data in early February, we made this projection. And so the data that we were observing are those black circles and bars, and the projection is this blue curve, and with very high levels of uncertainty, that's that shading. But we projected in early February that the B.1.1.7 would probably cause the majority of cases by early March. And around early March, the state also lifted the mask mandate, and we were concerned about what would happen during spring break as college students, high school students, families sort of relaxed their behavior, possibly traveled, and possibly brought virus back into the city, that would be an amplifying event. So in sort of leading into March, the city was concerned about the constellation of these different risks, but at the same time, we were continuing to roll out vaccines on the positive side. And so in response to a request from the city, we made some scenario projections. These were not forecasts, but sort of, if then. The pink line there was our projection for what would happen in ICUs if spring break, the statewide relaxation of measures and the variant didn't cause any problems. The purple line is what we expected if it was just the variant alone and there was no behavioral change. And then the other lines were kind of the more pessimistic scenarios where sort of the perfect storm of people relaxing their behavior, spring break being an amplifying event, and the variant exacerbating transmission. And what's actually happened since that projection is sort of somewhere in between, suggesting that the variant may have elevated transmission a bit, and probably behavioral change also has exacerbated things. Certainly, it's not the worst case scenario, but we could have been in even a better state under one of these scenarios. So what has happened in terms of what we're seeing at UT since those early projections? Well, as we all recall, we went into our catastrophic freeze in the middle of February, And, for some parts of the community that may have exacerbated transmission, but possibly for large parts, at least of the UT community, it may have pressed pause on things a little bit as people stayed home and didn't engage in their usual activities that can lead to transmission. What we saw following that was that indeed the variant has increased to become the majority of cases, at least in what we're seeing through surveillance at UT, but not quite as fast as we originally projected. But it's certainly here, and it may be partly responsible for why we haven't seen cases and hospitalizations decrease quite as fast as we had once hoped. So now I'm going to shift gears and talk about the vaccine rollout. So first of all, we're doing a pretty good job in Travis County. So these are counties in Texas with over 50,000 people. This is as of early this week. What proportion of adults over 16 and over have had at least one dose of a vaccine? And you can see Travis County, we have 61% of adults having at least one vaccine, which is higher than the sort of Texas average of 48%. And we're sort of in the top, looks like 8 or so, top 10 of counties in terms of the rollout. That's very positive. However, we're seeing again these sort of geographic disparities. So this is again the same map I showed you earlier of zip codes colored by social vulnerability index. And here are two other maps. The middle one is colored by our estimates for cumulative incidence. So how many people have been infected to date in the different zip codes. And you can see the pink means higher cumulative incidence. So there's been much more infection generally in the eastern parts of Austin than the western parts. And then the graph on the right is showing our estimate for zip code level vaccine coverage, with blue meaning lots of adults have received vaccines and red meaning fewer adults have vaccines. And you see sort of a similar disparity. So the more vulnerable communities have sustained more infection and tend to have had lower proportions of people vaccinated. This is that same three-way correlation, but just shown as a graph. So along each point represents a different zip code in Austin. Along the x-axis is cumulative incidence, so how many people have been infected to date. Along the y-axis is our estimate for what proportion of adults have had at least one vaccine. And the zip codes are colored according to social vulnerability. So the more yellow zip codes are our more vulnerable zip codes, and you can see they tend to be at the high end in terms of cumulative incidence and the low end in terms of vaccine coverage to date. So, we've talked a lot about herd immunity. It's sort of become a concept that many people are familiar with. It's this idea that maybe at some point we'll get to the point where there are enough people immunized in our population, either because they've been infected in the past or they've been vaccinated, that the pandemic has nowhere to spread and it starts to sort of dissipate on its own. And we may or may not get there, and that's a topic for future conversation, but the path there is going to look very different for the sort of the less vulnerable parts of our population in the West versus the more vulnerable parts of our population. And these are some plausible projections that I'm showing you on the bottom, going through time, where the light blue is showing sort of the proportion of the population infected. The dark blue is the proportion of the population that has both been infected and received vaccines, and the green are those that are vaccinated but were never infected. And you can see first of all, we estimate that it will take more immunity in the more vulnerable parts of our population to achieve herd immunity because it spreads faster, and that along the way, the population will sustain much more infection, and consequential morbidity and mortality than the less vulnerable parts of our city. We have asked the sort of hypothetical or counterfactual question of, what if we had we could go back in time and have prioritized vaccines by geography? So, in addition to prioritizing by occupation and risk, the 1A and the 1B, what if we had proactively tried to get vaccines to our more vulnerable populations? And specifically, what if we had apportioned the vaccines proportional to how much infection had occurred up to that point in time? And so, in the browner parts of the city here in this map, the more vulnerable parts of the city, what if we had given them 50% of the vaccines or 45% of the vaccines, even though maybe they constitute a lower proportion of the population? And again, this is what I'm showing you on the bottom, this graph. This is a hypothetical projection, but on the left, it's our estimates for how much how many COVID-related hospitalizations would happen in our low-risk community versus our high-risk community under the status quo rollout of vaccines. And on the right is the hypothetical, what if we had done this risk prioritized or geographically prioritized rollout? What we would expect is that we could have averted some of the hospitalizations that took place in our higher risk community without really exacting any cost in our lower risk part of the population. So finally, I just want to mention something about proactive testing. This is the idea of testing everybody we can on a daily, on a weekly, on a monthly basis, just as an extra safeguard and coupled with isolation. So if someone tests positive, they isolate, and this is a way to kind of prevent transmission and reduce the transmission rate as we're rolling out vaccines and until children, we're able to vaccinate children. So testing plus isolation, you might have heard in the news that everyone in England is now being offered twice-week COVID tests. And so this is a widely studied and somewhat accepted strategy for mitigating transmission, for catching people who are silently infected, getting them to isolate before they have a chance to infect too many other people. This is just sort of a diagram. Imagine this is a transmission tree of somebody infecting someone else. This is what the transmission tree might look like without testing. But if we were to test everybody once a week, starting at this point in time, those red circles indicate people who were detected, and the gray and the light red are all those infections that could have been prevented by detecting those cases and isolating them before they had a chance to infect others. We have done analyses in the consortium looking at whether testing makes sense from an economic and societal perspective, and the answer is yes, it makes a ton of sense. It can save, when you put a dollar value on hospitalizations and lives lost, it can be incredibly economical, saving billions of dollars on a national scale if we ramp up testing. And the amount of testing that we should do depends on the current risk in the community. If a lot of people have been vaccinated, if the reproduction number is low, we don't have to do nearly as much testing to achieve the same benefits. So now I'm going to get to sort of speculation about what we may be looking at in the weeks and months ahead. Before I give you some specific ideas, I just want to give shout outs to a couple YouTube videos of panels that I recently participated in that give a lot of interesting perspectives from other experts about where we're heading in the weeks and months and years ahead. The first one is one that was hosted by Stanford University on the science of herd immunity. And this is really talking about, these are experts talking about, what is herd immunity all about? What does that look like in the face of emerging variants that may evade immunity? What does this look like short-term or maybe even long-term in seasons and years ahead? And then this was a panel that I participated in that was organized by the National Academies of Sciences. And this looks at it from a little bit more of a sort of policy and kind of governmental and public health infrastructure. What do we do so that we are more prepared, more resilient? What do we need to do in terms of data collection, forecasting, public health preparedness, et cetera, to safeguard us against threats like COVID in the future? And now I'm just going to speculate, give a few possible things that might happen in the future based on the way I'm thinking about things today, and certainly conversations I've had with lots of other experts in the consortium and elsewhere. So first of all, I think that the U.S. is going to have to work really hard throughout 2021 to close gaps in vaccine coverage, and we're going to have to roll vaccines out to children as fast as we can once vaccines are approved. We're going to be fighting this battle for far longer. I think outside of the U.S., there are going to be persistent gaps and hotspots, particularly in more resource-poor settings that hopefully the U.S. will really step up and help to address. COVID may very well become a milder seasonal threat in years ahead. May look something like seasonal influenza, where we're sort of it remains something that can be a life-threatening virus, but we're able to we're able to give vaccines every year, and it's something we learn how to live with on a sort of annual basis. We will very likely see the emergence and spread of variants that we haven't seen to date, and some of those variants may evade our immunity through vaccination and through infection. I anticipate that a lot of our schools will be back in business as normal in the fall, our universities and our K-12, especially if vaccines start to become available for kids by the end of the summer. I think it's very likely we will continue to use masking and hopefully more testing while we're still rolling out vaccines to children as additional safeguards. I imagine that we might be entering a new era of cautionary behavior, testing, and pathogen risk mitigation. This is sort of anecdotal, and also looking around the world at other societies who have long adopted mask wearing as a way to protect against the spread of respiratory pathogens. But I can imagine that people will voluntarily wear face masks during flu season or COVID season when traveling in public transit or airplanes going forward, and maybe we'll even have public health guidelines during peak seasons where respiratory viruses are spreading, or specialized guidelines to high-risk individuals who maybe have underlying pulmonary or other chronic diseases. Maybe broader use of testing to safeguard against transmission of flu, of COVID in schools and other venues, and other strategies for risk mitigation. I think we'll probably be boosting for COVID in the years ahead. And maybe in combination with our flu shots. I'm hopeful that there will be a major investment in pathogen science, in data collection, in forecasting, and in fact, there already has been hundreds of millions of dollars set aside for creating a major national center for data collection and forecasting. The amazing work that the pharmaceutical and biomedical research industries have done in creating vaccines and trying to develop antibodies and drugs for COVID, I think will have benefits in the immediate future for COVID, and certainly as we face future threats. And hopefully, I hope we take this opportunity to really rethink and rebuild the U.S. public health system to improve our preparedness for future pathogen threats, to have a more coordinated, organized, respected decision-making process, and to address the stark socioeconomic, racial, ethnic disparities that we have experienced throughout the pandemic. So in closing, I'll just take a step back and share with you a comment I made in response to a New York Times reporter that asked me to speculate on what we need to do better next time. And my answer was that we really must overcome our collective failure of imagination. COVID took us by surprise. We spent decades planning for a pandemic, and I spent decades modeling for a pandemic that would resemble the viruses we already knew. We didn't plan for face masks, for mass testing, for stay-home orders, for politicized decision-making, or devastating racial disparities. And looking forward, we all need to prepare for a much broader range of threats. So with that, I'd be happy to take any questions and have discussion.
Great, Lauren, that was terrific. So only one slide of the future, but for somebody who loves to predict the future. So, but I understand there are a lot of variables that are unknown there, and lots that we can discuss going forward. I guess I'm going to ask my own question first. We've got a bunch of questions coming in the Q&A. Just to remind everybody, please use the Q&A, not chat, for your questions. But this, and we talked a little bit about this before, but you predicted this could become a seasonal infection, but we haven't seen much evidence that it's seasonal yet. But obviously we've got R's that exceed 1, so it's hard to have evidence of that. So tell us why you think it's going to end up being seasonal.
Yeah, and let me just caveat, this is super speculative, right? This is not based on rigorous analysis or modeling, so this is just me sort of speaking. but if you think about influenza pandemics, like the 1918 pandemic or the 2009 H1N1 pandemic, influenza is typically very seasonal, very predictably, comes up November, December, peaks, maybe December, but usually closer to February. And it's pretty predictable, that window. If you think back to those original pandemics that introduced new flu viruses that then evolved into the seasonal threats we face, those didn't happen during the typical time of year of flu, right? 2009, we first had a surge in the spring and summer, and then we had an unseasonably early surge in October, November. I think it peaked in October in most of the United States. And then we didn't see much of anything during typical flu season. And then the very next year, it came back seasonally. right at the normal time of year, and it has ever since. And there was a similar, I think the 1918 flu had sort of 3 waves also similarly. And so, so just because it's not seasonal right now doesn't mean it won't be. And it's, you know, when a pandemic first comes in, you have a totally vulnerable population. And so there's just a lot of fuel for the fire, right? After you sort of get through a pandemic, and, you know, in addition, if you roll out vaccines and there's just, and what happens in future years is you have a waning of immunity, but not to the point that everybody's susceptible. You just have a you know, lower opportunity for the pathogen to spread. And then it's sort of some of those seasonal factors that may amplify transmission. And what we think sort of amplifies transmission for influenza is the fact that, well, with flu, we believe it's kids being together, but just that people are coming together during the school year indoors in close contact. And that really, really helps to sort of provide opportunities for the pathogen to spread. And in addition, there are, at least for influenza, there's some evidence that climate makes a difference, that the lower the humidity is, the more easily the virus spreads from person to person.
Great. So we'll see.
We'll see.
Next question's yours.
Well, yes, and first, I just want to thank you, Lauren. That was a wonderful presentation, and I very much enjoyed it. And I'm looking at some of the questions that came in advance, and many do refer to masks. One question in particular, what criteria would be required to change a mask mandate on fully vaccinated individuals? So what might we look for to allow public mask wearing changes?
So I'm not sure when the question came in. Was that just today? Because
oh, this came in yesterday.
Yesterday, okay. I'm trying to remember when it came in relative to when the CDC just came out with some mask guidelines the day before yesterday. And I don't know, imagine many of you saw them, but they were pretty clear, color coded. If you're, one column is if you're vaccinated, the other column is if you're not. When and where you should wear vaccines, and where you should wear masks. And you know, for the most part, it was saying, you know, vaccinated people can feel comfortable going without face masks if they're mostly around other vaccinated people. But once you're doing things where you may be around unvaccinated people, particularly indoors, you should continue to wear face masks. It provides some level of protection, you know, in the off chance that as a vaccinated person you actually get infected. It also provides sort of reassurance for people who are not vaccinated or are newly vaccinated. They don't know if the people in the room have been vaccinated or not, so it might just make them feel a little safer. And it just sort of normalizes it for people at a point in time where it's not safe for everybody to go without masks. You know, for example, children, right? So they don't have the option to vaccinate at this point. So at this point, it's sort of, I think some of those recommendations are coming from a place of like solidarity and just sort of, you know, limiting transmission to some extent. For people who are unvaccinated, it's recommended that you always wear masks essentially, you know, unless you're really sort of outdoors at a long distance. And so when do we move to a point where we can say, hey, forget those charts, we don't need them anymore, you know, wear a face mask if you feel like it. I think it's really about what proportion of people do we have immune in our population? And are you going into a place where you're pretty sure everybody in there has had an opportunity to get vaccinated if they want to? And we're not going to get there until we can vaccinate children. And so, you know, I'm hopeful that, you know, by late 2021, we're at a point where we've really been proactive about closing gaps, making sure that people who haven't vaccinated yet, it's not because they didn't have access or didn't have information or didn't have time, and we get the vaccines out to kids.
Great. We are now getting a flood of really good questions, so answer them quick so we can get to more of that. So this next question is from Manish Nayak, and he's asking about, you showed us surveillance, you know, active surveillance as a way to control outbreaks going forward. And the question is, well, how often should we do those, like in a controlled environment like a college? And then would it even be necessary in fully vaccinated patients?
Yeah, and I would distinguish between surveillance and proactive testing. So just some terminology. Like, so it's good for us to be doing surveillance just to track what's happening. And, the real focus, this is a little bit of a tangent, the real focus of surveillance now is ramping up sequencing so we can do more surveillance around, variant stuff. So this, what I was talking about is really proactive testing as just like a gatekeeper. You want to find people who are silently infected. And I think, at this point in time, I would say it's not that important to be doing that for vaccinated people. If and when we get to the point where we know we have vaccine evasive variants spreading, we might change that, our thinking around that. But at this point, if things sort of stay as they are for going back to school in the fall, and some kids have been vaccinated and some kids have not, specifically testing those that have not been vaccinated and those that have not had a positive test in the last 30, 40 days. You also sort of give them a window for that as well.
So frequency based on, when was your last test kind of thing?
Frequency, sorry, that's if they tested positive. Sorry, if somebody, right, so you give them sort of, if, you assume that,
not be positive. Sure.
Or you could possibly exempt them permanently. Like, those are sort of details that may depend on the situation at the time.
Good. Nancy, you got another one?
Well, I do. Dr. Tierney was interested in specifically what level of herd non-immunity will keep the SARS-CoV virus smoldering. So what level is required to significantly reduce our risk?
Yeah. So again, I'm going to point you to the Stanford panel because this discussion can be so nuanced, but let me just say that if in sort of the perfect system from what we know about COVID, we probably would need about at least 70% of people immunized one way or another, effectively immunized one way or another to really slow the transmission. Might be 60, might be 80, depends on, but that's like kind of in a perfect system. You can have that level overall, but if you have pockets where you have low levels of coverage because, it's a group of people that are all vaccine hesitant and they all, there's sort of a cluster, social clustering that sort of interact a lot with each other, or you have socioeconomic pockets or parts of town that just haven't had as much access, that can undermine, even if you have a high, overall level of coverage. So it's not just about how many people vaccinated, but it's about kind of the evenness of coverage. And so we need to and right now we know that children are clearly a huge gap in coverage right now that we have to fill at some point soon. And that's sort of locally, and then there's the global picture. Like, we may get to the point in the United States where we've closed most of those gaps. We've vaccinated children. We've really sort of brought things under control, and we've seen the virus, mostly fade out in a lot of our communities. But if on a global stage, we still have pockets of low immunity, countries that haven't vaccinated, and the virus continues to spread, that just poses sort of that risk of seasonal reemergence because that virus can be spreading, variants can be emerging and can come back and threaten us, in years ahead.
And with that said, do you have any travel recommendations? I know that's first on the list for many people as they become vaccinated, international travel resuming.
Yeah, I mean, I think people who are vaccinated can cautiously be traveling. It still makes sense. Certainly a lot of airlines and government agencies require masking, et cetera, when you are traveling. And I think, keep an eye on things. If there's a country that is having, a major surge in COVID and there's variants being reported, that's probably a riskier place to travel. The other reason you don't want to, this is sort of setting aside your risk of exposure to COVID, the other reason you don't want to travel to places that are struggling to contain COVID is because if you end up needing healthcare in another country that is battling a surge, healthcare for another reason, you may not be able to have, access to safe and rapid care. So I think being cautious about travel, taking baby steps, but I think it is a time where we can start to take those steps.
Right.
So I don't know if you're going to be able to answer this, but people want to hear you try. So this is from Colby Evans. What's the best estimate for vaccine EUAs for 12 to 16-year-olds and for those under 12?
I have no idea. I ask at least 2 people that question every day.
Yeah.
I don't know.
Yeah, I'm on the DSMB for one of the AstraZeneca trials, and I'm a semi-insider, and I have no idea when that's going to get approved either. I mean, I think it's just there's so many factors that go into it. So let's hope soon that could be the answer. Nancy, if you've got I've got a bunch, so I can keep going.
Why don't you go ahead? I think we've covered most of the questions on my list. You know, one in particular was vaccination of children. You just asked that. So go ahead with your questions.
Great. So I think this one's an important one too, and you're the right person to answer this. This is from Jack Verosco. So the pandemic models have not always been consistent in their predictions. And of course, they're trying to predict different things, right? So you predicted different futures based on behavior. Some of them presumed the behavior and then made a prediction. But what are the learnings from that? Some were just off. You know, so what worked, what didn't work? How do we take this into the next pandemic and do a better job? I'm sure you're talking about that all the time.
Yeah. One thing we have tried to do throughout this pandemic when asked to make projections is to really be very clear that there's a lot of things we can't predict, because this, you know, during this pandemic, unlike in like flu seasons, we have changed policies and changed behavior in ways we can't predict, right? Like we've stopped leaving our house. We've gone out of our house. We've worn face masks. We've not. And so because we don't have a crystal ball about those kinds of changes in behavior, it's been really difficult to make projections beyond like 3 or 4 weeks out. Because a governor can make a change, or you know, there can be a national change, or et cetera, or people can just, you know, there can be sort of contagious behavior. So for that reason, and I did this at one point in this talk where I sort of emphasized these are not forecasts, these are scenario projections. And actually the very first request we got to make a forecast was back in March of 2020, and it was a request from the White House Coronavirus Task Force right after Dr. Birx took the reins, and they asked us and a lot of other modeling groups to side by side make a projection for how many people are going to die from COVID in 2020. And so while I think other groups made projections, we said, we're not going to give you a forecast. We're going to give you 3, you know, what if projections. You know, what if we don't do anything to control the virus? And then we projected, like all the others did, that it would be over 1 million deaths in 2020. What if we basically stay locked down or figure out a way to repress transmission as much as we are during our lockdowns? Well, then we can limit deaths probably to under 50,000, which is sort of, you know, on par with a typical influenza season. And if we do something in between, you know, our sort of in-between one was a roller coaster type thing, we projected that there would be around 400,000 deaths in 2020, which is sadly, you know, about what happened. I mean, it's probably had over 500,000 deaths, you know, when you account for unreported deaths. So anyway, so that's one thing we've been cautious about, but we, you know, as sort of on the technical side, the folks that do this kind of modeling have learned so much about what models are working, what models aren't, what variables to put in, what techniques work. And I think, you know, some of that early learning came from this widely viewed and discussed projections by IHME out of Seattle. And they took kind of an unorthodox approach to forecasting the pandemic. And their forecasts were cited by Trump and by Birx and sort of making some of those original decisions. And their unorthodox approach was, instead of baking all the science in about how the disease spreads from person to person, about how we have different parts of our populations, they said, well, we see in China, this is what the pandemic did. And in Italy, this is what the pandemic did. In New York, this is what the pandemic did. So we're just going to assume our curve is going to look like that. And we're going to kind of tinker with that curve. So it was called a curve fitting approach. And so that was an example of a method that was actually made the most widely disseminated projections, but then fell short once, you know, we entered this multi-wave thing. And so there's been a lot of progress and some validation, some retrospective, and there'll be a lot more of that. And one of the goals of this new federal initiative to set up a data and forecasting center that will likely be located or co-located with the CDC is to really take a collective, a kind of an ensembling approach, and this is what the CDC sort of does now, where we take lots of different kinds of models, we compare them, we figure out what works, what doesn't work, and we do a better job of getting the right kind of data collected and into those models.
Yeah, and just, I mean, this is more my question than your question. So I mean, obviously the models really focused on the impact of COVID as they should, but they produced, because of that focus, um, recommendations about controlling, COVID transmission, and those had unanticipated consequences that we quickly realized, right? That we knew there'd be economic consequences, and that would have an impact on health. And we knew there'd be mental health consequences, and that would have an impact too on global health as well. And we've seen some evidence that that's the case, with more suicide deaths, more overdoses. So any data on that, though, really to say, places that locked down more had more of that, and that was a cost, and that should also be integrated into a future model.
Yeah. So I cannot speak to like the science of it. That is an active area of research, and I think it's going to be mixed. I think that we'll see that people are going to find correlations between lockdowns and the mental, social, psychological costs. But there's also going to probably be examples where more lockdown, but more kind of effective messaging and mitigation strategies. Mental health mitigation strategies sort of corrected for some of that. So I don't know what the science is, but it's an important and really active, area of research. And I'll just mention, I think that, you point out a really important limitation to most of the models that we and others have been using is that we're pretty myopically focused on the virus, the hospitalizations, the cases. And, we sometimes indirectly think about costs, but usually in terms of like monetary terms or these very vague terms, which are how long are we in a lockdown? And what we really need to do going forward is modeling in a more kind of holistic way, what is a pathogen threat really about? It's not just about the pathogen and making people sick, but it's about, the repercussions of our mitigation strategies on people's, social well-being, mental health well-being, et cetera.
Yeah, that's going to be really important to integrate that, have a better view of it. Hopefully it'll teach us something too about overdose and depression, anxiety, all these issues that are increasing in the United States anyway, well before the pandemic.
Yeah.
So question about information. You mentioned that we're going to learn from this, we're going to do better next time. So what changes in health information sharing exchange should the U.S. invest in to deal with future pandemics?
That data, all the EHR data needs to be immediately, totally available to researchers, to public health agencies, to decision makers at all scales. And that has been such a challenge. One of the reasons I think Austin has sort of done well in maintaining good situational awareness and making good decisions is because of this really unique collaboration between leadership in so many different dimensions, and the fact that the hospitals were really collaborative and provided data to the city leadership on a daily basis that's not available in almost any other city. And that made a huge difference. And there's a major push by HHS to finally get facility level data available, but it's still just really spotty, the availability of the data. So really it's, we have to worry about privacy issues and, all those things, but we can do that. We can figure out the right way to do that and make sure this kind of data. And sort of going back to your prior question, it's not just the EHR data, right? There's all these other, like the vaccination data, the testing data, the school absenteeism data, the mental health data, right? We really need to be thinking about surveillance from a more holistic perspective as well.
Great. So you're a flu person. You became a COVID person, but you're going to go back and be both. And so, we had no flu this year, right? It was remarkable. So the question is, are these things going to come back with a vengeance, worse next year, because now we have whatever new strains, no one's been exposed to them, boom, they're all introduced at the same time, the behaviors are like they used to be. What's your prediction?
Yeah, I don't have a prediction. There are things that could point us in either direction. So, positively speaking, people got vaccinated for flu this year. We had pretty much normal levels of vaccine coverage for flu, and I anticipate that we'll have, you know, pretty good coverage next year as well. People are kind of in the mode of vaccination right now, and, you know, kind of hyper alert about respiratory viruses. So hopefully we'll have a decent amount of vaccination. Because there was not much of a flu season last year, there may be just a lower level of population immunity going into this year. Because there was not a lot of flu last year circulating around the globe, you know, not just in the United States, there may also not have been that much antigenic evolution of the virus, right? You know, the way these viruses evolve is if they're actually infecting people and they're confronting people who have immunity. So I don't know if I don't know if we're going to see more, you know, vaccine evasive or immune evasive strains. But the one thing I think is that well, this is one of the things I sort of speculated on. I wouldn't be surprised if we see more cautionary behavior during flu season. If people sort of voluntarily, or, you know, wear face masks, or we even decide that that's going to be a, you know, a proactive recommendation we make, you know, during.
Yeah, I mean, isn't it also possible that we could have made some of these strains extinct for flu because there was so little transmission? I mean, I realize there's there's always some out there, but
yeah, it's possible. It's possible. Yes. We'll say,
okay, yeah. Well, the last question was actually to me, and it was whether I could turn my camera towards the residual Breckenridge facade. So I'm going to try this. I hope I don't induce nausea here. I'm going to do it slowly because I can't turn my computer, but I can turn the camera. And hopefully the light will show you that we are losing a lot of the old facade of Breckenridge.
Wow.
It's coming down. Lauren, I want to thank you for a great presentation and a wonderful discussion. I think you brought us all up to date and had us thinking into the future. We got to about half the questions, but a bunch of great questions too. So really appreciate you being with us today. So this will be recorded. You should have seen the link for CME, but you can also track that on the announcement that comes out with the next one. But CME is available for this one and will be for the next one. We'll see you back next time. Nancy, I'm going to let you send us off.
Well, I'm just going to echo your sentiments. This was wonderful, Lauren. You gave us a lot to think about. And so I'm very appreciative for your comments. To our viewers, please stay tuned. We will continue to have virtual town halls for our medical community, and I found them very educational. So we look forward to seeing you at our next. Thank you, everyone.
Thank you.